Blast off.
Good evening, all. I'm Rohit Kotode. I'm working as a senior product executive at Chlorama, and welcome you all for DADI Dermapath Academy and Diagnostic India Private Limited presented analyze real world dermatology cases, histopathology, and educational support by Chlorama. First of all, I would like to thank you to Dr. Sasi sir, Dr. Manoj sir, and Dr. Nandakumar sir to giving an opportunity to present in the platform. And thank you to all PGs, those who are joined with us. So Gloderma, now I would like to introduce about our Gloderma. So Gloderma have a core value that is elevating life, and core purpose is elevating lives, and core value is meaningful innovation, unwavering commitment to the quality and safety, continuous improvement, result through teamwork, and aspiration core value that is customer success above all else. Gloderma have a 7+ launches first time Indian brands, 14 for the 400 plus enterprising Glodermians, and 130th ranked pharma company in the country. We have a 700 plus distribution networks and 9,000 plus associated dermatology. Gloderma have a skilled R&D team and develop innovative formulation. So Gloderma have a product mix like a antifungal, moisturizer, acne care, and hair care. Along with that, we have a psoriasis care, topical steroid, vitiligo care, and nutraceuticals. Now, Gloderma is India's first company who all make products in paraben-free, sulfate-free, and detergent-free. So, patient safety is of a paramount concern. Now, I would like to introduce about our flashy brand that is Moist, the most advanced moisturizer and cleanser. In Moist, we have a clinical trials, and it is tested by dermatologically. So, in Moist, we have a Moist cleansing lotion and Moist Syndet bar, a Moist XL and Moist cream, Moist MM, and Moist LMF48 long moisturizing formula. Along with that, we have a ketoconazole range that is Kion. The advantage of solubilized ketoconazole in lipid phase. In Kion, we have a ketoconazole Kion Stay On lotion, Kion soap, Kion zip, Kion tablet, and Kion cream. Along with that, we have a Minoboost in the management of early stage AGA and advanced hair loss. So, Minoboost, the complete hair regrowth therapy. In Minoboost, we have a 4 SKU that is Minoboost 5, which containing minoxidil 5%, Minoboost F5, which containing minoxidil 5% and finasteride 0.1%, Minoboost F10, which containing minoxidil 10% and finasteride 0.1%, and Minoboost Progain. Along with that, we have a oral therapy that is Minoboost 2.5 mg scoral tablet. So Gloderma have privilege to launch India's first molecule that is ozenoxacin, novel non-fluoridated topical solution. In Ozedix, we have a cream, 5 and 10 gram, and along with that, we have a lotion which containing ozenoxacin 2%. Also, Gloderma has a tie-up with a Sanosun Baby, which is made in Germany brand, premium pediatric skincare solution. So, Gloderma have a tie-up with a Man and Shoulder company, which bring world-class derma-tested, certified with a natural and safe baby skincare products to Indian mothers. So, Sanosun Baby, German's premium baby skincare, one global, one formulation, 14 plus years of expertise in baby skincare and presence in 70 plus countries. So Sanosun Baby till now gained the trust and confidence of 250,000 plus Indian mothers. So Sanosun Baby made with a more than 90% natural ingredient, 0% SLS and ACLS free, and clinically tested hypoallergenics. So Sanosun Baby with a milk protein and organic olive oil. So that's all about the Gloderma. Thank you so much, all of you. Now I would like to hand over the session to Dr. Sasi sir.
Great. Thanks a lot, Rohit and Glodama team for facilitating this. So I'm going to share my screen and get started because we're already late. Can you see my screen now, everybody?
Yeah, yes, screen is visible. Yeah.
Okay, excellent. So we've got two co-panelists, Dr. Shishir Das and Dr. Lavanya, who have Dr. Shishir Das is the winner from last time. So Dr. Shishir, congratulations once again. So what we're going to do is we're going to discuss these cases one by one. We've got 10 cases. Now, we had 10 this time because I thought there would be 5 people in the panel. And in fact, 4 of them, 3 others have actually paid to be in the panel. I'm not sure why they're not here. Anyway, so let us just start off. Dr. Shishir, maybe because you've been waiting for a long time, you can start off with this case. First one, which is a 40-year-old male with a cutaneous lesion in the scalp present for 2 years. Lesion was shaved with radiofrequency and the biopsy was taken from the base to rule out malignancy. And yeah, this is the histology picture. Obviously, a cutaneous horn clinically, but this thing is to look at the histology, and that is the main purpose of this. So maybe we'll Nandakumar sir, do you want to start off with this case, and Dr. Shishir Das will probably try to describe the findings.
Yeah. Good evening, Dr. Sisarda. Can you just start off describing the findings, the scanner view?
So the scanner view, it shows skin covered tissue with some part of panniculus, dermis, and an ulcerated or eroded epidermis. Most of the epidermis is severed probably by electrocautery, and if we can go to higher power, we can see that the keratinocytes are slightly elongated, and the nuclei look desiccated. All these the epidermis part. So it appears to be that the effect of radiofrequency cautery has played a part in this morphology, and there are lots of blood vessels in the upper dermis, and so here we can see an island of keratinocytes with abrupt keratinization at the center, and the periphery has slightly palisaded appearance at the basal keratinocytes. So it is probably a follicular origin. And we can see many dilated blood vessels high up in the dermis. Some of those appear thrombosed to me, and some RBC extravasation is also there, which can be due to the surgical procedure. The collagen is slightly bluish.
So you think it is a neoplastic condition?
Sir, from this cut, actually, I cannot comment properly, because I think the architecture has been altered by electrocautery to a great extent.
Yes.
But I cannot see any invasive procedure or invasive infiltrates around the nerves or vessels in the deeper structures. So, in my point of view, this is at least not something malignant. This is a benign condition. So this much I can say.
Very good. By the way, perhaps I missed. Can you introduce yourself, your specialty, and where you are working now?
Sir, I am Attili Das. I am currently working as AIIMS of dermatology at Malda Medical College Hospital. It's in West Bengal, Malda district.
So you are a dermatologist, basically.
Yes, I'm a dermatologist.
He's a dermatologist, and he's actually one of the co-editors of the the Indian Journal of Dermatopathology. So I forgot to introduce him because I know him very well. I presumed everybody knew him, but
So
my mistake.
nice meeting you. Doing a great job. Right. I think there is a purpose in keeping this slide for discussion, isn't it? So,
Yes, sir. Yes. Dr. Lavanya maybe also wants to comment before we go ahead.
Sir, I was thinking the tumor part has been removed, and what we are seeing is just the base of the tumor, which shows lot of degenerative changes in the collagen, and a portion of the tumor which is showing tricholamel differentiation. So what I thought is like a benign adnexal tumor, possibly of hair follicular origin, and the base is free of the tumor.
Okay, Dr. Lavanya, do you want to introduce yourself, please, again, for the sake of the audience?
Yeah, I'm Lavanya. I'm a pathologist working in Sri Venkateshwara Medical College Hospital as a professor.
And this is in which city, madam?
This is in Pondicherry.
Pondicherry. Right. Okay. Welcome. So, the purpose of this particular case is that the clinician, what they did a shave biopsy with a radio frequency cautery, and then they biopsied the base. Now, this is the point of putting up this case is all we are seeing here is entirely cautery induced changes. In fact, this may be a follicular structure. This probably is a follicular structure, but it's been cauterized. So I wouldn't comment on this. I am not even sure if it's part of the tumor. It obviously, a cutaneous horn is a tumor of some description. It could be an actinic keratosis, could be anything. But here, I'm not even sure this is part of the tumor. This could be an incidental hair follicle there or follicular structure which is entrapped within that. And when I report this, I basically said the procedure is basically wrong. If you want to really biopsy or find out if there's a tumor, you have to either send the cutaneous horn in toto, or you have to, with a blade, neatly cut the top and then biopsy the base. Once you've cauterized it, you've basically, completely fried up all the changes that are supposed to be there. So I reported this as an inconclusive sample, and I said if this if recurs, then you need to rebiopsy. But the whole purpose of this is for the clinician to make it to remember that if you want a biopsy of the tumor, don't cauterize the base first, otherwise you won't get the lesion. And secondly, for a pathologist, you should not commit yourself anywhere in this particular sample because this is a cauterized sample. So personally, I didn't commit myself, but Dr. Nandakumar sir, would you commit on this particular sample?
No, no, I won't. I'll just give it as with a comment that the sample is inadequate with a lot of changes, probably induced by radio frequency. We can
Yes.
even make out at the 1 o'clock position. That is what is called as a pseudo polyp appearance at the 1 o'clock position. It's due to the forceps, the tooth to forceps picking up
That's one.
picking up the tissue
Yeah.
and the pseudo polyp appearance. In fact, it is a slide for beginners to learn the artifactual changes that can be present due to inadequate handling.
And we had Dr. Manoj Singh sir in one of the previous meetings nicely, we had discussed these changes, and Dr. Sisudas has nicely picked up on it, that these elongated keratinocytes, and this is a repetition, and I thought this would be good for a repetition because it just, homes in the point that we previously discussed. Manoj Singh sir, anything else to add?
Yeah. Just see this in the high power, lower power. Okay, enough. The surgeon, you know the surgeon?
It was one of the junior
You must make
working
friends
with
with
my
him.
dad, actually.
He's done a brilliant. Hey, excuse me, just a minute. I'm getting a phone call. Haji?
हेलो
हाँ
वो खाना खा लिया था
हाँ मेरी मीटिंग चल रही है एक.
अच्छा चलो ठीक
So, the person has done a beautiful job of. I guess you can't see my pointer, but at the margins and the lower edge, it's a nice scalpel biopsy. You make that?
Yes.
Yeah.
Right.
And then at the upper edge, for some reason, in order to separate it from the horn or whatever it was, the person has applied the cautery. And electrocautery does cause this kind of an electro streaming effect. And this, as Dr. Nandakumar nicely pointed out, this is my well-known saber-tooth artifact. I'll show that sometime. I've got that in several of my PowerPoints. A tooth forceps does this. And people have this tendency because obviously the tissue will slip in a plain forceps. So they catch it with this, pull it up, and at times destroy the morphology. I totally agree that this whole thing is cautery effect. Now, why the person wanted to remove the lower part of the biopsy? Usually you see this cautery effect in the, in the lower and the lateral part to remove a large tumor or something. Why the person wanted to use a scalpel here and a cautery here?
It's a punch, sir. It's not a scalpel. Punch.
Huh? Whatever. Punch. It's a nice clean cut and a sharp punch also.
No,
No
because the
crushing there.
cutaneous horn was very thick, they could not punch through it, so they cauterized the top and then they punched the base.
Sir, I
Well,
can answer.
anyway, it's a nice appearance. As Dr. Nandakumar says, very nice case for teaching artifacts.
Sir, I
Yes,
can
Dr.
answer this because I have been in the shoes of this junior dermatosurgeon. What happens is comes and after removing it with radio frequency ablation, think of okay, maybe something malignant was there in the base. Let's do a biopsy. So, and for first frequency severing this and then taking a biopsy with incision.
You mean they
Because I
didn't
have done
they didn't
that.
want to take a biopsy initially, and then once they cauterized it, they then realized that maybe
Yeah.
they want to take a biopsy later. Maybe.
But usually, a cutaneous horn does not grow ab initio, unless it's multiple cutaneous horns or something. Usually, it's consequent to a seborrheic keratosis, squamous cell carcinoma, well-developed, whatever. So, obviously, the person thought that there was something there. But, I mean, might as well have, held the cutaneous horn like this and cut around it with a scalpel, thereby giving you the entire sample. But why remove
So,
the cutaneous
okay.
horn and then biopsy is
Yes, yes. So let us see. I mean, the purpose, the point system. I thought in this particular case is not to diagnose anything malignant here, and if somebody has made a specific diagnosis, that is wrong. So cutaneous horn, I think it's a non-specific diagnosis. People can get full marks if they put in cutaneous horn, is my opinion, because it's a
no,
safe diagnosis. Just a cutaneous
no,
horn.
no,
There's
no,
no
no.
there's no malignancy there.
In the
What do
biopsy,
you?
there is no cutaneous horn.
No, there is no cutaneous horn, but
Oh,
that's true. I mean, actually my diagnosis was inconclusive. Inconclusive, not possible to be
fine,
connected to
fine,
technical
fine,
issues.
fine. I would go along with number 6.
Yeah, that is
Whoever
number
said
one,
number 6.
obviously. So if we want to give cutaneous horn something, we can, because that's a clinical diagnosis. Somebody has just decided to go along with the clinical, and most of them have decided to go with the clinical. So up to you. Nandakumar sir, what do you think?
No, I don't think we should give any credit for diagnosis of cutaneous
Yes,
horn
yes,
because
yes.
I think the very purpose of discussing this slide is that clinical the clinical impression maybe it is cutaneous horn. Agreed,
Mm,
but
mm,
there is no cutaneous horn in the slide. So how
mm,
can you make a sign of something which you are not seeing? So I would
mm.
also go with number 6.
You would also go with number 6. No marks to any of the others.
Yes.
No, no,
So, benign head neck stroke, trichiloma,
no.
dermatitis artifact. I guess they were
It's,
thinking
it's not a
they could not find
dermatitis.
this. So,
It's
I
not
think
a
let me,
dermatitis.
no, just a second. Let me just slightly qualify this, because they may not have found this in the drop down. See, because the drop down list has about 4,000 different diagnoses.
Mm.
They were probably searching for artifact, and because they didn't find artifact in any of this thing, they've gone for dermatitis artifact, is my subject, my thinking. Maybe Shishir, who's taken the quiz, would know better. Shishir, what do you think?
Actually, I put on 6, and I thought another diagnosis would be viral wart because of the thrombosed dilated blood vessels in the upper dermis.
No, you found 6, right? You found 6.
Yes.
It was easy enough to find. My question is, because we said this is an artifact and there's no pathology artifact or some other different diagnosis. They may have gone for dermatitis artifact is my only concern, because they may not have found that inconclusive diagnosis in the drop down list. But it's not dermatitis artifact, of course. Okay, anyway, let them, if somebody has put that, and they can message me personally and we can give them marks if that is the reason they put it. Fine, let us see. So we're not giving marks for any of the others right now. We're just only giving 1 mark to this. Is that correct, Dr.
Number 6.
Manoj and Nandakumar sir? Yeah?
Yes. Yes.
Okay, fine. Okay, I'll just submit that and close it. Okay. Fine. So going back to the next case, case number 2, Dr. Lavanya probably can answer this. This is a 20-year-old male with tense bullae present over both palms, present only on summer, no other symptoms. And I'm not given any clinical pictures deliberately, because this is a classical. Dr. Lavanya and Dr. Manoj Singh sir, maybe you'd want to guide Dr. Lavanya on this.
Okay, Lavanya, you start off.
Yes,
Let's
sir.
see.
Okay, so this slide shows a punch biopsy of the skin with acanthosis and hyperkeratosis. There is spongiosis with very large bullae seen within the epidermis, intraepidermal vesicle, spongiotic vesicle seen. So I thought of dyshydrotic eczema of Phomphelox.
That was a very quick spotter.
Well, sure. Just one pointed issue. Spongiosis usually refers to separation of the epidermal cells for
Yes,
whatever
sir.
reason, which you see here, right? You
Yes,
see,
sir. In the
this
lower
is
down,
spongiosis. Lower down, there's
yes,
something else. The epidermal cells themselves are getting sort of degenerated. So there are two processes going on here, which are, cousins, but not related. Like, this is classic spongiosis, this small one, right? But in
yes, sir.
between also, you have areas where the epidermis itself, because the cell is getting distended, so the cells themselves are looking kind of
Balloon down.
ballooned and degenerated. And these two processes can at times be misleading because they are due to different processes. So, here, of course, in this case, there is no problem in this particular case. But many times these two can be, right at the edge now here. This is a classic spongiosis, you can make out from right in the end is almost normal, then little more spongiosis.
So
And then you
technically, is
have
this acantholysis? What is your opinion on this? Is this technically acantholysis?
But
uh,
the bridges are still seen, like the projections. It is not
Yes.
acantholysis.
rounding.
Classically, acantholysis is actually, a separation because of separation of cell from cell. So the cells first off get rounded off. Here, as she very rightly says, there is, the
Bridges.
intercellular junctions are there. They're pulled out, but they're still there. So,
Hmm.
this is an increasing amount of spongiosis going on from here to here.
Absolutely. And I thought that was an important point to point out for others listening to this and seeing the video, the pictures, because they may be asking the same question: is this acantholysis? Why is it not acantholysis? In case, I think that's a good clarification point
Yeah.
for juniors who are learning.
What would be the differential diagnosis that you, if there are any, to be considered?
We can think of psoriasis because psoriasis over the palms can have eczema-like features, spongiosis and spongiotic vesicles can be seen. But here the spongiotic vessel, the size is very big.
Yeah,
We cannot think
absolutely.
of
Absolutely.
psoriasis.
Psoriasis as a definite, the classic 5 or 6 types of changes in which, of course, spongiosis is there, and then thickening of the epidermis, acanthosis is there. But the even if it is bulla and psoriasis, it is associated with so many other changes. Here, there are none.
It is not there. I mean, I'm not saying that this is psoriasis, but with the clinical history, I think that would be one of the DDs that one would consider. Something like palmoplanar pustulosis or
Hmm.
psoriatic lesions occurring as pustules on the palm. All that comes into the differential diagnosis. This is a classical case
Yeah,
of
yeah, yeah,
pamphlets. I agree.
yeah, yeah. You see, for psoriasis, you would never have these totally bland kind of
Yes,
thing.
exactly.
And
Correct.
no neutrophils here, and
Yeah,
parakeratosis is very
it is
scanty.
not there. Not
Very
there.
large bully and almost totally bland.
Yes.
Yes.
Sir, can we also think of dishydrosiform bullous pemphigoid where
This
capitalization has occurred?
Well, no, no. Bullous pemphigoid is, as you know, a dermoepidermal lesion.
No,
And you
after
do,
depithelialization, if the lesion is slightly older, then
yes,
it can.
totally. I was, yeah. I would agree with you as a thought. But the issue is that when, I mean, in a healing bullous pemphigoid, which also we have seen, in a healing bullous pemphigoid, there is healing, you know, sort of from the bottom up, healing has occurred. This is not healing. This is a lot of spongiosis going on here also.
And
And
usually
that means
eosinophils are seen.
if this was a bullous pemphigoid, then, I mean, I have also seen that a bullous pemphigoid has healed and then a bullous pemphigoid has happened again. So, this explains the gross morphology, the layer on top and layer in the middle and all. But then here again, if you see above the basement membrane, this is not healing. This is an ongoing process. And that ongoing process is not bullous pemphigoid. It's some kind of degeneration. There is spongiosis and this, that, and the other. Those are not features of bullous pemphigoid. So I would not think. No, I don't think so.
Okay. So are there any other questions, Dr. Shishir or Dr. Lavanya? Shall we move on to the
Yes, sir.
marking? Okay.
Sir, while describing it, should we call it acanthosis? Keeping in
That's a
mind
good question. I don't think personally that is acanthosis because it's an achial area. It's difficult to confirm.
Yeah.
Given that it's achial, yes, you're quite right. It's probably difficult to say that is definitely
Yes.
acanthosis, but there is definitely thickening, but that is site related. So
So there is
that may not.
hyperkeratosis also, which
Yes,
again is, site related.
it's site related, and you can see the nice equine duct. Somebody who's
Oh, yeah.
learning in
Oh,
the
yeah,
achial
yeah. Oh, yeah.
areas.
Oh, yeah.
Nice equine ducts, beautiful equine ducts going through.
Sir, so during description, can we comment that this is sample from acral skin and completely omit all the epidermal features related to that?
Yes, you can. That's what I would probably do. I didn't actually comment on the epidermis here when I was reporting. It's just achial skin. So case number 2, let us see. So 18, everybody has called it dyshydrotic eczema, most of them. Then the pseudoporphyria, equine hydrocystoma, atopic dermatitis. So yeah, I'm not giving any others marks. So we'll just close this very easy. Only 6 different answers. So excellent. So let's go back to the images then. So Dr. Shishir, you've got a 62-year-old male, red lesions and mild itching present all over the body for 20 days, aggravated since the first week of onset basically. History of fever for 4 days, stiffness in small joints and red colored urine. History of multiple erythematous to hyperpigmented scaly plaques node all over the lower abdomen, lower back, abdomen, extensor aspects, forearms, elbows, extensor aspects, legs. Relative sparings of flexures, views, changes on fingernails, partial edentism, DD erythroderma secondary to psoriasis. So this is basically, I've not made it into a quiz. I've just put in sign out cases here. These are all my routine sign outs that I've put in. I've not changed anything in the history apart from maybe deleting some obvious diagnosis here. So I just wanted you to experience what a sign out looks like. And some of the history is confusing, some of it may be pointers. So these are clinical photographs. Uh, Photograph 1 from the legs, photograph 2 from the hand. This is from the buttock and thigh area. This is from the back, and this is just in the legs again. Okay. So let's go to the histology. Nandakumar sir.
Yeah. Dr. Sisardas is describing, isn't it? Yeah.
Yes.
Please go ahead.
So we can see skin covered tissue, which where there is psoriasiform regular acanthosis with some parakeratosis, and there is little or very mild inflammatory infiltrates in the dermis. If we go on high power, I think I can see parakeratosis more easily. There are dilated blood vessels, tortuous capillaries very high up in the dermis, along with suprapapillary thinning, and I can see some neutrophils in the stratum corneum, where focally there is complete loss of granular layer. I think granular layer lost in almost entire throughout the epidermis.
Yes.
And there is a very mild lymphomononuclear infiltrate along the perivascular space in the papillary and upper dermis, with some melanophages in the dermis. I don't see any prominent interface change in the form of degenerating basal keratinocytes or squamatization.
Is there?
But is the basal cell layer intact?
Is there?
So there is some hypertrophic changes. I am not sure whether they are melanocytes or degenerating keratinocytes.
Look at the tip of the papillae, that uppermost part, tip of the papillae.
Tip of the papillae. Okay,
Upper.
one or two.
Yeah, this one, just go to the top. Yeah, here. Now, this is definitely degeneration going on.
Okay,
And
sir.
you can, I mean, if you, as a matter of argument, you can do a PA stain and, also demonstrate this even better. But this also is one of the classic changes you see that, differential involvement at the tip of the papillae and lower down.
Okay, sir.
So how are we expected to sign off this report?
So I would say this is psoriasis, probably going into erythrodermic phase.
So how do we explain the macular degeneration?
Sir, I think during acute inflammatory process, there is some macular degeneration, some interface change happens, and finding dermal melanophages is not very rare in these settings. And I will also consider any drug-induced causes for this flare of psoriasis. In that case, the interface changes can be expected.
Excellent. In fact, to summarize the histological features, we are actually seeing a combination of two patterns, isn't it? In areas it has got psoriasiform change, in areas it has got lichenoid type of basal cell vacuolization, the dropping down of pigment, etc., isn't it? So there is a combination of pattern along with dilated prominent capillaries in the upper dermis without any features of vasculitis. They do not show any features of vasculitis, just dilated capillaries. And the infiltrate, whatever we can make out, is scattered throughout the upper part of the dermis. I don't know whether we are seeing any eosinophils among the infiltrate, but I would go with your last, the diagnosis, the second diagnosis that you offered. To me, it looks more like a drug-induced erythroderma rather than psoriasis leading on to erythroderma. It's again a slightly difficult slide to sign off, but the features I felt was more in favor of drug-induced erythroderma rather than erythroderma due to psoriasis.
So can I make a point? There was
Please.
some collection of neutrophils in the stratum corneum layer, like whatever little stratum corneum we are seeing.
Yeah,
There were
that is exactly what
neutrophil collection.
that is exactly what I was saying. It shows a combination of patterns, and drug-induced lesions do show this tendency for combined patterns to be seen.
You see, the issue is when those 5 or 6 or 7 points of diagnosing psoriasis, the guys in the West give it so much importance because it's a very important thing to them. Here we do see one very nicely forming pre-Monroe microabscess, right? It's not yet become a Monroe microabscess, it's kind of getting there. And then the classic pathognomonic sign of psoriasis, spongiform pustule Kogoj, right? Which is described as 2 or 3 inflammatory cells present in a vacuole. Here, everywhere there is spongiform pustules. The whole thing is spongiform. So, as Dr. Nandakumar very nicely summated, that there is a very great mixture of things going on here. It can still be only a psoriasis. I have no doubts about that, because all these are very pleomorphic kind of diseases. And when you say drug induced, drug is something, because everybody takes drugs and sometimes they get reactions. But would it not be better to call it a psoriasiform reaction? Look for the change. Look for if they have not given any history of drug, because I would call it a kind of an acute. And actually, if it is psoriasis, then it's been going on for some time. All that pigment incontinence and melanophages and all also indicates that this area is not a very acute process. It's a mixture. Acute stuff is going on. Chronic has been there for some time.
So, how much vacuolar interface change do you normally accept in psoriasis?
Any amount. Any amount. Let me
Any
tell
amount,
you,
this much as well.
in a psoriasis, which is otherwise looking okay. I mean, this one also, okay, so somebody sends to you as a psoriasis, you say, okay. Now, in this, there is a lot of vacuolar change, right? You are seeing quite a lot of vacuolar change, this, that, and
Yes.
the other. I usually like to think of these as, this is a acute condition which has been going on for some time. So,
So
acute or
the way
chronic kind of a thing.
I interpreted it is, given the amount of sheer amount of vacuolar interface change, and also, in fact, if you look at this, the normally in psoriasis, in my experience, the reticulars should appear bulbous, and
Actually, yeah,
here they're all almost sawtooth, like you see in
yes,
lichen
yes,
planus.
yes, yes.
So, given the amount of interface change, I actually thought definitely this is a combination of both psoriasiform and interface dermatitis. And given the age of the patient and the sudden flare up, I thought this was definitely, I mean, drugs would definitely should be high up on the
Yes,
list
yes.
when reporting. And that's what I said, that this has a combination of features, definitely psoriasiform and interface. Given that the classical psoriasis features are not, are not predominant, there is a
Yeah,
predominant vacuolar interface change in melanophages, drugs should be considered, especially for the flare-up of the acute erythrodermic presentation of the patient.
yeah.
Um, so I think that's what Dr. Nandakumar sir also felt, right? Nandakumar sir, did you have any other thoughts?
I saw
Are you there?
some eosinophils also among the infiltrate.
Did you see some eosinophils, sir?
No, I didn't. I didn't.
No. Yes. Eosinophils we discussed this earlier, may or may not be there. They're not a very hard, if they're there, then you may think about, but even if it's not there, that doesn't matter. The drugs can still cause reactions.
Yeah,
Um,
eosinophils is something which has always thrown me for a spin, because here in Delhi we get a lot of biopsies also from, Eastern India, where a patient's eosinophil count might be 40%. So, how do you explain that there are eosinophils present in the lesion?
Yeah,
You know?
it could be a very non-specific thing.
So that from that point of view, yes, definitely, eosinophil is part of the allergic immunological reaction. So you have eosinophils. Classically, Dr. Nayak used to teach that if you see eosinophils, go away from tuberculosis in granulomas and so on and so forth. So I, in fact, was the first one to ask him, sir, what do you do about a patient coming from Bihar who comes to you with TB or leprosy? How do you interpret the eosinophils there? So he laughed. Obviously, he didn't have any answer for that, but
hmm. So, okay. Dr. Shishir Das and Dr. Lavanya, do you have any questions? Shall we move on to the answers?
No, sir.
Okay.
Sir, actually, for this case, I want to give a pattern diagnosis because I was not
Yes.
sure of any, but the
Yes.
options are not there
Let's see.
actually.
Let's see what. So
what
we'll
do you
give
think?
answer. Let's see what marks. So erythroderma, likely psoriasis. So we don't need to mark everything as 1. We can give them 0.5, we can give them 0.25. So Nandakumar sir, would you give 1 for this, or 0.5 or 0.75? If you're dividing them, we've got drug eruption as well. So we can divide the marks, up to you.
0.5 for the first one.
And drug
Yeah,
eruption?
but I mean, look at it this way. Okay. So psoriasis and then, yeah, okay.
And drug eruption?
Again, I think it would be 0.5 or 0.75. Nothing.
Yeah,
I
drug
won't give
eruption, I
1
Yeah,
mark.
think.
drug eruption can be anything.
Yeah.
The fact is, like the number 1 says, that this is a psoriasiform lesion which may be drug induced. Let's put it like that.
Correct. That's
Or
a
this
better
may
way.
be an
I thought of the
erythroderma, psoriasis, and then again say maybe this may be drug induced. But if you're not said psoriasis at all, then
Agree. In that case, I think erythroderma, likely psoriasis, deserves 0.75.
yes.
uh, Sir Manoj sir, just said I also thought in the same line, but in the drop down I could not find any psoriasiform drug eruption.
That's okay. But
That's
see,
okay. See, it's a relative thing. So you can drug eruption, if you're given 0.25, we're going to give marks to that. So it's fine. Everybody's in the same boat. So the way we work out is you can give a differential diagnosis of 3 or 4 even. So it's fine.
however many cases you might have in your drop-down menu, the number of diagnoses which we will make in dermatopathology will always be more and more and more. So I mean that's okay. As long as your thinking is on the correct lines, I think you're fine.
Okay.
So on a similar pattern, I think drug eruption, I think it's not wrong. I think it's right. 0.5 for drug eruption, because I mean, drug eruption is a really good, that because you have noticed
No,
drug eruption.
listen. This is pathology. This is pathology. Drug eruption is if the clinician has said that, okay, drug was given and this has happened, then that's a clinical diagnosis. Here, what is there to show a drug eruption?
No, sir, but I think if you are thinking, because this is not a specific diagnosis, we are not giving a descriptive, they're not giving a report. They have to choose one diagnosis. And given that you've noticed 2 patterns, if they have picked out drugs, they should be given marks. Because they have noticed the fact that they've thought about drug eruption means they've noticed 2 patterns. Otherwise, they
Tell
wouldn't
me
have thought
something.
about drugs.
In this biopsy and in this match, what is there to suggest a drug?
The 2 patterns, the lichenoid and psoriasiform pattern. Once you see 2 patterns, you have to think about drugs.
But then that is covered in number 1. That is not covered in number 2. Because, I mean, if there is only, small thromboses are there in the dermis, and we say this is a drug reaction caused by some kind of a drug. That is also a drug reaction. Here, there is, you see, you have to look at the thinking. You have to look at how they have reached that particular diagnosis also. From that point of view, number 1 is, now erythroderma, psoriasis, psoriasiform lesion, drug-induced psoriasiform lesion, this, that, all that does get covered in 1, but not in 2.
Dr. Nandakumar sir, what do you think?
The problem is in the wording of that second diagnosis. You cannot call it as drug eruption. No? Histopathology wise, how can we call it as drug eruption? It would have been better if it was qualified with the reaction patterns also mentioned or something like that. But just to call it as, we get an exanthematous drug reaction also. Will that look like this? No. So that is the problem here. Perhaps in the drop-down menu, people didn't see that appropriate.
Well, they can see, they have an option of giving 50% marks to erythroderma psoriasis, then they can give 50% marks to lichenoid dermatitis or lichenoid dermatosis. So they can do that, in which case they'll anyway score marks, even if they don't have drug eruption in there.
Yeah.
So,
but the drug eruption, I mean, is too vague terminology in this particular slide.
Yeah. You see, as I said, the drop-down menu, however hard work Sasi might do on it, it will never keep pace with, especially now that we are moving away from classic cases to, this kind of cases. So there now you have to say that, okay, now you are thinking of 2 things or 3 things, and you have to see now in the drop-down menu what fits.
Okay.
So it's
So
a test of not only
you both
observation.
think drug eruption is 0. Okay. What about psoriasis vulgaris then?
It's
No,
not vulgaris.
it is not vulgaris.
Okay. This is not CTCL. Lichenoid dermatosis should be given some marks.
There you should give something, yeah, because as you rightly said, that's one of those wishy-washy things. Yeah, like or
So
not,
I
you
think
should.
0.5 for that, 50% of the
Point five.
diagnosis.
Yeah,
Point five.
yeah.
And the
Okay.
same for this. We're not giving anything for post-symptomatic hyperpigmentation, even though they're melanophages.
No.
Lupus, I guess, because there's a lot of vacuolar interface change, they've gone for lupus, but there are no other features of lupus. I'm not sure if you should give any marks to that. I don't know.
Well,
No marks.
see, systemic lupus erythematosus, no. If it is, it's a very, very acute lesion of lupus. This,
Mm,
right?
mm.
Now, if you have it in the drop-down menu, then okay. Otherwise, why bring it in here? Systemic, it's not.
Yeah, it's not clinically. You have to also correlate. No, systemic lupus is not clinically that
Even
anyway.
histologically, SLE to
Yeah.
nahi hai ye. A
Mm.
very acute lesion in SLE or whatever it
Yeah.
is.
Yeah.
But that then,
And I guess the only thing else is writer syndrome, but then writer syndrome, the clinical is not for it. And
yeah.
I don't think we can call it that. So shall we close it at that?
Yes,
0.5
Yes.
for
yes.
Yeah.
lichenoid and then 0.75 for erythroderma, likely psoriasis. Okay, fine. So moving on to case number 4. I don't know if this is submitted or not. Just a second. Okay, submitted. Right. So case number 4, I think we are now near Dr. Lavanya's chance. So 13-year-old male accompanied dark lesion on left side of chest for 3 years. Well-defined hyperpigmented patch over the left mammary region for 3 years. Mild itching, lichen fusion present over the lesion. The lesion is gradually increasing in size. And that is the clinical picture. You can see mild, slightly lichenified, but hyperpigmented patches, 2 of them. Both of them are similar pictures, actually. Okay, so this is the histology. So Dr. Manoj Singh, sir, you maybe want to guide Dr. Lavanya on this one. Dr. Lavanya, are you there?
Yes, sir. So
Yeah,
can I start describing?
Yes,
sure,
please.
sure.
Yes, please.
Yes. So this is a skin biopsy showing the epidermis shows acanthosis, irregular acanthosis with mild papillomatosis.
Yeah.
The stratum corneum looks normal, basket oven orthokeratosis. And there is hyperpigmentation in the basal layer. And the dermis appears normal with very mild lymphocytic infiltrate, perivascular lymphocytic infiltration. The rest of the dermis appears normal. So I was thinking of an epidermal nevus for this case because correlating with history at the time of puberty, there is increase in size and hyperpigmentation, lichenification, all that thing. So I go for epidermal nevus for this case.
Yeah.
Manoj Singh, sir.
Dr. Lavanya,
Yes, sir.
that's that almost black-looking lesion. Do you think this is black enough for that?
There is increase in the I was
Yeah.
thinking of basal melanocytes, but might be there is an increase in melanocytic. No, I feel it is
Okay.
increase in basal melanocyte is
My actually not really a question, but my suggestion to you is, what would happen if you do, say, for example, Fontana Masson on this?
sir. I didn't get you, sir. Sorry.
What would happen if you did a Fontana Masson on this case?
There'll be increased.
Or an HMP45? See, the issue is our pink and our blue stain, the usual one, melanin gets lost. So, even if you see this in the higher power, you say, okay, yeah, a little bit increase, little bit increase. But I think it's totally out of context with the clinical picture. Because little bit increase is, like my skin. But that lesion is, much more. And that is the reason I'm, kind of just commenting on this, that if you do, for example, an HMP45, if you do, Fontana Masson, but very important thing which I have discovered over the recent past. I mean, in a lab which is not, tuned to immunohistochemistry, ask for a toluidine blue.
Okay.
Ask for a toluidine. I'll send some slides, Sasi. I think we should scan this. Ask for a toluidine blue and specify that you want a very light toluidine blue, very light. Because, sometimes they think toluidine blue, usko kar do, dark blue kar do and all. Ask for a very light toluidine blue. See it. Very educated. One of the books, I don't remember which one of the special stain books, said something which has stuck in my mind for 40, 50 years. Talking about melanin, they say that these toluidine blue and related dyes, they turn melanin beautiful bottle green. Beautiful bottle green for a pathologist is, we'll say, wow, what a nice term to use. And it actually does turn melanin blue or green. And that is a very dramatic appearance because that will be not only in the basal layer. You'll also find what you are not seeing in the HND. In these other stains, you'll find that there is more melanin present higher up also, which is adding to the whole effect. Here, you are able to make out only the, basal layer of the epidermis. There, you'll be seeing it in, higher up also. So the total quantum of melanin will be much more in these cases.
What is your diagnosis, sir, on this one?
Oh, I agree with her. I think it's an
Okay.
epidermal nevus.
Yes, okay. So, Nandakumar, sir, do you have any other thoughts?
Can we have a look at the clinical image once again?
Yeah, sure. Oops, sorry. I'm not able to zoom in on this, but
Yeah, it's okay. It's okay. Any other possibility that we can think of apart from epidermal? Yeah, epidermal nevus, it is a nevoid condition with the blunt acanthosis and basket weave hyperkeratosis, etc. It could be epidermal nevus. We get to see, especially in adolescent age group, we do see quite a number of biopsies where the large hyperpigmented patches. This is slightly the surface is slightly rough or verrucous, but strictly bland patches of hyperpigmentation we do see. Even recently, I saw one patient whom a biopsy was done. The biopsy was done to rule out a nevus or some related condition. How do we sign off such reports? There is a minimal increase in the pigmentation in the basal cell layer. Yes, Dr. Zisradas.
Sir, we have been seeing cases just like this, where a very well demarcated patches, dark patches, which resembles acanthosis nigricans, and when we biopsy, we get this exact histopathological pattern, and the entity we have searched is called idiopathic eruptive macular pigmentation. So there has been lots of publications saying idiopathic eruptive macular pigmentation, especially in this particular age group of adolescent children. And we see this, we have seen in our institute at least 3 or 4 cases till now.
perhaps are they just creating a new name for an existing variant of an entity, Dr. Shishudas? What do you think?
So some people think that this is acanthosis nigricans, a variant of it. So
Or an epidermal. Why could it not just be an epidermal nevus variant? It's a nevoid hyperpigmentation. Probably a variant of epidermal
the
nevus. Why could it
author
not just be that?
divided on this. Something that the variant of nigricans.
If not for that
So why
clinical,
should it be a variant of Acanthus nigricans? Why can't be a variant of
yes,
an epidermal
yes.
nevus? Why
If
are you
not for the
inventing?
clinical lesion, clinical description, I would also consider Acanthus nigricans in this. That can have exactly like this.
But why Acanthus nigricans? Why not an epidermal nevus? Why is it just
Both,
not an epidermal nevus?
both, which is why we are talking about dermatopathology. Not, you shut your eyes, and then you send it to the pathologist, and you tell the pathologist you're supposed to guess what you're doing, which is what I face at times. That you don't get an adequate. Here, of course, you've given us a very nice clinical history and pictures, and then we see the morphology. So that is a different kettle of fish altogether. But without all this, why not?
Sir, what we have found in our institute, these cases, they respond to topical retinoids very nicely, and that should exclude the diagnosis of a nevus. I think
Well,
nevus they do not.
So are you saying that they don't recur after that? They respond to topical retinoids and they go away completely?
So we have not followed them for many years.
Because even epidermal nevus responds well to topical retinoids, the flat ones. And yes, I mean, the response, that's a well-known treatment for epidermal nevus. That doesn't exclude it, to be honest.
see,
It becomes, you can only exclude it if it clears up and doesn't recur again. And because if it's a nevus, because the cells are there, it'll again recur once the topical retinoid is taken away.
if I may interrupt, Cecil, if
Yes,
I
sir.
interpret your department's philosophy, you saw, for example, 10 or 15 cases like this, and you tried your treatment on all 10 or 15, and 4 or 5 responded, right? So you feel that, this might be a separate subgroup, which you are saying.
Sir, this has been discussed in literature for many years. I think it was
So,
first described in 1970 or so, and lots of case reports are available.
so no, what I am asking is, in your particular example, 5 cases responded, 10 did not. Okay. Now, the secondary question which Sasi is asking, that whether it recurred or not good, let's not go there. 5 responded, 10 did not, right? But
Yes.
you had a case, total of 15 cases, which showed this morphology or similar morphology. So, at the time of morphology, were you able to distinguish? Or did you go back and try and compare the morphology of the
Yes, sir.
5 which have
We,
responded to this one?
yes, sir. We did clinical-pathological correlation on that part, and
Significant differences in the cases which responded compared with this kind of a morphology. Were there any in this group of 5, for example, compared with the 10 which did not respond? Was there any noticeable difference?
sir, I did not get you.
What I'm saying is that you have 15 cases which look like this,
Yes.
roughly, huh?
Uh,
And
I would say 3 or 4. I would say 4.
and an example, just
Yes.
an example. No, three or four have responded. There must have been 4 or 5 or 6 others. So, which is why I'm saying, supposing you have 15 cases which have come to you with a morphology like this, and you say, okay, in my department, we will try following treatment, or following groups of treatments, or following, different types of treatments.
Okay, sir, I got your point.
And
Yes.
4 or 5 have responded. Were
Okay.
you able to make out any significant difference in the morphology of this compared with the morphology of that?
Uh, I have not paid that
Have a
much.
look. Have a
That
look, because
I have to check that.
if you see a significant difference, then I think you are well on the way to writing. I mean, this might have been reported as case reports for 30, 40 years. That's not relevant. If you are able to delineate that these 5 cases actually had a morphology which is slightly different, and there was some click there, and that relates to the fact that they responded to treatment, then you have a world level paper. That's what I'm saying. That's where my thinking goes. So just have a look at the cases of the slides again, and you see. The second question will come out later is what Sasi asked, whether it recurs after sometime after treatment or not. That is different. But the point is, at the moment, please see if there is some significant difference.
Okay, sir.
Okay, we'll quickly move on to the marking because otherwise we'll be running late. So, 8 people have called this Becker's nevus. What do you say, Nandakumar sir?
We, we need some additional features also to call it as Becker's nevus.
There's no hair at all, and
Yeah.
I mean nevus certainly, but it's not a Becker's nevus.
It is not a
Becker's-
Becker's nevus.
It's not a Becker's nevus. It's
Yeah.
close, but it's not a Becker's nevus. Just because it's a nevus on the chest doesn't make it Becker's nevus. So Manoj Singh, sir, you agree?
I totally agree because little bit down there is an epidermal nevus is there anyway.
Yeah, acanthosis
Diagnosis
nigricans
is
is
there.
also there. Second one.
Yeah. So
are we giving acanthosis nigricans marks then?
I think so. Yes. Why
I
not?
think
How
we
many
should
marks?
give.
Why not?
How many marks do you want to give it?
Clinically, you guys tell me. Otherwise,
No,
microscopically.
clinically it is not acanthosis nigricans.
Clinically, I would give it 0. Clinically, it's not acanthosis nigricans.
It is not
Okay.
acanthosis nigricans.
Okay, then yes, I agree with you totally. But what I started off saying was acanthosis nigricans has.
No, histologically, there are a number of
You're right.
overlaps.
You're
but,
fine. You're okay. Right.
Similarly, lichen simplex chronicus,
No.
unfortunately not.
No.
Epidermal nevus is the only thing that in my
Yes.
dictionary that would get 1 mark.
Yes.
Prurigo pigmentosa, no. Inflammatory, definitely there's no inflammation to call it
No,
ILVEN.
not ILVEN.
Acanthotic
No.
sepke, not. These are
No.
not all. These are not clinically possible. So epidermal nevus is the closest diagnosis I would give a mark.
I think with CPC only epidermal nevus is among the answers.
Yes.
That deserves a mark.
I am submitting that and moving on to case 5. We have to move on. We have to move fast for the remaining cases, otherwise we won't finish today. So let's move on to case 5, and hopefully this will be an easy case. This is the clinical 75 on male. This was a very long history for a very simple lesion, so I was confused. A 5-year history of itchy rash affecting the entire body, including abdomen, back, legs, chest, scalp, genital area, associated with itching and pain. 75-year-old man. Multiple 2 to 4 erythematous plaques with mild surface scaling. Node on the abdomen, chest, verruciform pigmented growths observed on the upper back, scalp, left temple. Lots of treatments, including insulin and all that, and then lots of, I won't go through the list, hypothyroidism for neuropathy. I mean, he's got the whole textbook and the whole pharmacy in his body. And this is the clinical picture, and I put that deliberately. I put the clinical picture here so that it's helpful. And that's the 2 clinical lesions. The pictures are not that great, but you can still make out what they biopsied. So Dr. Lavanya, I'll probably go through this one quickly for sake of time. Do you want to describe the histological features here?
Yes, sir. So the skin shows irregular psoriasiform acanthosis. The acanthosis is reticulate type, very thin reti ridges coming down, and with the occasional horn cyst is there. The dermis shows little bit lower down. There is perivascular inflammation with melanophages, and
Yes. What about
so
the papillary dermis? Is that normal?
the papillary dermis shows it shows vertical streaking of the collagen fibers.
Yes. And anything else? What about any keratinocytes looking normal?
The keratinocytes, I didn't find atypia in the keratinocytes.
Okay.
Little bit basaloid I felt, and because of the horn cyst also, I thought of seborrheic keratosis, reticulate type. But because of melanophages, I was also thinking of drug reaction. Little bit lower down in the dermis, there are melanophages around the blood vessels. So I was also thinking of a drug reaction in this. And there were plasma cells also, if I'm right.
Plasma cells may have been there. I didn't actually pay attention, but probably there are 1 or 2. Okay, fine. Yeah, there are plasma cells.
May I ask a question?
Yes,
On
sir.
the high power. Oh, sorry. On this power. The low power. You know, melanin and melanophages come in from the basement membrane, right?
Yes, sir.
Why are they not there in the papillary dermis? Why are they present as a band lower down?
There is some reaction happening, like fibrosis taking place in the
Yeah,
papillary
yeah,
dermis, which has
yeah.
pushed the
Something is happening.
melanophages down. Some reaction,
And that is the reason for the fibrosis there, right?
Yes,
yes.
yes. That streaking, vertical streaking, and all which you were saying is exactly that. That whatever happened there is being pushed down. But just one difference of opinion I'd have with you. Your first sentence, your opening sentence. This is not psoriasiform hyperplasia.
Yes, sir. It is
This
like
is
reticulate
not psoriasiform.
elongation, not reticulate also.
When you have acanthosis, it may be psoriasiform, which is a very classic form of bulbous pegs and all that.
Regular.
But it is regular. This is not regular.
It is irregular.
Hmm.
Dr. Shishirdas, what did you think?
Sir, I thought of seborrheic keratosis, reticular type.
Yes, yes. So I report this as an inflamed seborrheic keratosis, reticulate type, obviously.
Okay.
But this is obviously, so you have to qualify, this is an inflamed seborrheic. This is not a normal seborrheic keratosis, and obviously it's inflamed. That's why the patient is itching. And he presented with generalized pruritus for that particular reason. All these seborrheic keratosis suddenly became itchy for some reason. He's on polypharmacy, so something could have triggered an immune reaction against benign keratinocytes within the seborrheic keratosis, and that may have led to the reticulate appearance also. I don't know. The clinical appearance is that of a flat seborrheic keratosis, and older people have flat seborrheic keratosis.
So he's
Uh,
been itching for how long?
I'd have to go to the history back again. 5-year history, not
Oh,
recent.
oh.
And he's got enough reasons to have itching anyway. He's on so many drugs and he's on got so many other comorbidities. There's enough reason for him to start itching. Thyroid, he's got neuropathy, he's got diabetes. So enough reasons. Dr. Nandakumar sir, any other thoughts?
No, it's inflamed. I would also sign it off as inflamed seborrheic keratosis.
Yes, yes.
Inflamed or irritated seborrheic keratosis?
Yes. Yes.
Not a
Absolutely.
lichen simplex chronicus.
No, no. Because the superficial part of the epidermis doesn't show features of lichen simplex chronicus.
So there are vertical alignment of collagen bundles, but that doesn't make it lichen simplex chronicus. That is just suggesting that there was inflammation previously, as you pointed out, sir. And in my opinion, yes, the patient may have scratched it, and there are features that the patient lesion has been scratched, but that doesn't make it lichen simplex chronicus.
No, it doesn't. No, it doesn't.
Uh,
LSC, I mean, that fibrosis is all right, but in LSC, you'll have a prominent feature of A, hyperkeratosis, and B, the acanthosis will no longer be this kind of reticulate. It'll start becoming more and more cushion-like,
yes.
especially if there's something going on for 5 years.
Yeah,
So
hyperkeratosis typically is compact hyperkeratosis in LSC.
Yeah.
yes. So I'm not sure if I'm pretty sure I had inflamed seborrheic keratosis in the drop down. Dr. Shishirdas, did you find inflamed seborrheic keratosis in drop down or did you not?
I started with seborrheic keratosis, probably inflamed. So after finding seborrheic keratosis, they came in alphabetical order.
So I have a question. Sir,
So there is irritated seborrheic
irritated
keratosis
seborrheic
there.
keratosis, we should see squamous eddies
Hmm.
like that. Here, there were no squamous eddies. I thought of irritated first, but because I didn't see any squamous eddies,
I don't think that is absolutely necessary. You're right. That is a classical description, but then this is irritated, inflamed, they are synonyms, right? We don't need to try to differentiate between them that much. As long as I think seborrheic keratosis you have to identify first, and then you have to identify there's inflammation within it. So ideally, irritated seborrheic keratosis would be, I would give full marks, but nobody has actually chosen that. Most people have gone for seborrheic keratosis and acanthotic seborrheic keratosis. Um, so we have to decide what to give them. What do we give seborrheic keratosis? Are we giving them full marks?
Yes, seborrheic
Yes.
keratosis, yes.
But irritated seborrheic keratosis is actually the right answer. Nobody has chosen that.
But yeah, this acanthotic seborrheic keratosis, what it is?
I don't know what that is. That is there in the list. I didn't delete
I
it.
mean, I
This is
mean, if it is not acanthotic, then why is it seborrheic keratosis?
so that's not okay. Fine. We'll just club it with seborrheic keratosis. We won't try and differentiate. So if we are giving marks to that, we'll give marks to this. Are we giving full marks or 0.75 for there
Okay,
is irritated seborrheic keratosis in the differential?
then give it 0.75.
0.75. Nandakumar sir?
Yeah, I agree.
Okay. But if I'm giving this, I'll give that. I don't think we'll penalize them for calling it
It's
acanthotic.
okay.
Melanoacanthosis, lichen simplex, adenoid BC, benign inflamed keratosis. So, I don't know what that is.
No.
No, we cannot.
Okay. So, stucco keratosis, again, stucco keratosis, I guess,
No.
but it is not a stucco keratosis. Stucco keratosis should have a typical church square pattern.
Stucco is a very, very characteristic
Yes.
appearance. This is not characteristic of seborrheic keratosis at all.
No. And somebody has gone for drug eruption again.
Maybe mistook one case for the next.
No, I think
That is a problem with our original case where we showed the combination pattern and all. Drug
yes.
eruption per se is a very vague, answer.
Yes.
Cannot.
I guess you can think about drug eruption here. It's not nothing
Yes.
wrong, but
Yes.
this is not a
Yeah.
drug eruption.
Anything can be a drug eruption, yeah.
Yeah. Okay. So we're given 0.75 and we're closing it. That's fine.
Sir, if
So
seborrheic
let's.
keratosis appears in the setting of internal malignancy, don't they become pruritic?
They
That's a
will.
good thing to
They
think
may.
about, but
They
5 years is a long time, no?
And they tend to be multiple, no? Numerous. Numerous.
It will be eruptive. It will be. It may be itchy, but not go on for 5 years.
So, is it possible that previously present seborrheic keratosis becomes itchy after developing malignancy or anything?
Anything is possible, I guess. But 5 years is a long time, no?
Okay.
If the history was 6 months or something,
the
then you can think about malignancy. But again, you can't see that we are making histological diagnosis. You cannot diagnose malignancy on a seborrheic keratosis histology. You can write that in a histology report that somebody is present with eruptive seb case, then you think about malignancy. But when you're reporting histology in a quiz type of pattern, you can't call it malignancy.
Yeah.
But that's a good thing to think about. Yes. So this is a classical histology. 40-year-old male presented with weakness of upper limbs and numerous skin-colored papules over face and trunk. Deliberately kept the history very vague because the histology is classical. So who wants to? Dr. Shishir Das and maybe Nandakumar sir, you want to take?
Oh, yes. This can you describe?
Sir, we can see a skin biopsy where the epidermis is atrophic with attenuation of red ridges, and there is a vague sparing of a grain zone below which with the uh, dense infiltrates of some spindle-like cells, and there are some epithelioid histiocytes also in the upper part, and a storiform pattern, a vague storiform pattern can be visible. If we go slightly downwards, so can we go to the deeper section? We can see nerves embedded within the infiltrate, and there are multiple foamy histiocytes in the along the neurovascular bundle, and also splaying in the in between the collagen.
Diagnosis?
Sir, I think this is a histoid Hansen's histoid. Proceed.
Why it is not lepromatous leprosy?
Okay, sir. I to rephrase that it is a histoid, not.
Yeah.
leprosy.
So this is actually a pretty classical case, and I didn't actually put in the fight for echo, but fight for echo was beautifully positive. I'm just trying to find. Can you see my screen just now?
Yeah. Okay.
The fight for echo, can you see it?
No, I cannot.
Okay, let me just share that and that explain that so show this fight for echo as well. My screen, okay. Second. Can you see this now?
Yes.
Yeah.
So this is the fight for echo on this case. Beautiful. You can see the bacilli. I mean, numerous teeming with it. This is one of the classical cases where you see numerous bacilli. It's a variant of lepromatous leprosy, obviously, but you see spindle-shaped cells, and the clue here is the foamy cells actually, and that was well spotted by Dr. Sishidas, well spotted by you that is the the clue there, and obviously of the deeper involvement along the neurovascular bundles. But here, this one other thing I want to point out is this section is not suboptimal. To me, when I see a section like this, I there is some amount of fixation issue here because the cells are much more bluer, and also the epidermis. To me, I mean, it's thinned out. There's no grain zone here, by the way, Dr. Shishirdas. There's no grain zone here at all. The epidermis is atrophic because the infiltrate is impinging upon the epidermis, and the reticules are completely
Grain
taken
zone.
off, right?
Grain zone.
So, in fact, there's no grain zone here. This is one example of lepromatous leprosy where you're not seeing a grain zone, and therefore it's basically the grain zone is in my dictionary it doesn't exist actually. I mean, it doesn't exist as a diagnostic pointer. I don't use it at all in any condition.
Focusing at the periphery of
Yeah, but
the
even otherwise, I do
yeah,
not use grain zone as a pointer in any condition. Just because a grain zone is there or not there, it does not change my diagnosis. And
yes.
here in this case, even though there's a grain zone here, that doesn't mean anything to me. And I wouldn't call it a grain zone because it doesn't mean anything, grain zone. It's a very overrated thing, grain zone. I don't know what others think, but let's see what Dr. Nandakumar said, Manoj Singh say. I do not use that as a differentiating factor. Manoj Singh sir, do you use that as a differentiating factor?
I'm quite comfortable with this, calling this a histoid.
No. I do. What do you think about the grain zone as a feature? Do you use that as a differentiating factor?
Grain zone.
You comment on it.
You're right. This usually in leprosy, most leprosies, grain zone is free, and grain zone is free in many other conditions also because of the difference of collagen. But
Yes.
here, and in fact, even if you consider histoid leprosy as an expansile lesion, you have a lot of expansile lesions in the dermis, and many or most of them do spare the grain zone. Even if they push the epidermis up, they push the grain zone along with it because again the different type of collagen.
But do you use the grain zone do you even comment on the grain zone when you're reporting, or do you use it as a differentiating factor when you're looking at differential diagnosis?
Not really. I mean, like I do look at it in the sense that something like lichen planus, the grain zone will be. Then you have something like lichen sclerosus heterotrophicus. The grain zone will be free and it will be sclerosed. So you have those conditions happening where it may have some redness. Otherwise, generally speaking, grain zone is uninvolved in most inflammatory and other conditions. So I like to just kind of.
Sometimes the clinician would want us to differentiate between a nodule of a lepromatous leprosy from histoid leprosy.
Oh.
In such situations, I have found the presence of grain zone to be a pointer towards it being a nodule of lepromatous leprosy rather than it being a histoid leprosy.
Yeah, you're right.
If you are not seeing so many spindle cells.
But does that change the diagnosis? Why does the clinician want to differentiate? Because
Yeah,
by dictionary,
exactly.
both are treated similarly. Why do
You
we
know,
want to
hystoid leprosy, the diagnosis of hystoid leprosy, it causes a lot of excitement among the clinicians.
Yeah.
Okay. So we'll go to the marking of this case quickly for lack of time. So histoid leprosy, Hansen's, that's getting 1 mark. Somebody called it
Yes.
lepromatous. Are you giving them? But it's specifically histoids, but they call it lepromatous, which is good. They've got
Yeah.
the diagnosis.
This is the point which I would like to make. Here there is no green zone. No grain zone, and the infiltrate, at least in the upper part, is composed almost entirely of spindly cells. So a
Yes.
diagnosis of plain lepromatous leprosy doesn't hold true here.
Not correct, yeah.
Mm.
See, for
But then
example, number 3
they've
diagnosis
called it
may be
leprosy,
leprosy.
right? So we should give them some marks. They've called it
Yeah,
lepromatous leprosy,
Yeah,
same spectrum.
if somebody calls it leprosy only, will you give them marks? Here you
They'll
have
give them
given
some marks. That's not wrong. They're not wrong. The
here
the
you have
patient won't
given a
die
very
because of it. He'll be
specific
getting
and a
the right
very
treatment,
beautiful
right?
pattern. And if somebody is not recognized that pattern, then I think I give them 0.
Sir, I think you're being very strict. See, the patient is still getting the right treatment. See, the patient is not dying. We are looking at safe people who are reporting safe. So lepromatous leprosy is still a very safe
Okay,
diagnosis. They're not dying
okay.
because of it. They're getting the right treatment.
we'll give 0.5.
0.5, I think my opinion is 0.5 because yes, histoid leprosy is one. Lepromatous leprosy is still not a wrong diagnosis. It is still within the
ठीक है,
spectrum.
ठीक है, ठीक है.
Uh, diffuse neurofibroma, colloid milium, everything else, obviously, we are not giving them any marks. Hansen's leprosy, BT, no, unfortunately, it's not BT.
I think diffuse neurofibroma. I think it is it's a point worth discussing. This is how we miss a diagnosis of hystoid leprosy.
Diffuse neurofibroma.
Yeah. I have come across quite a few cases where slides have been sent to me for review, which turned out to be hystoid leprosy, originally reported as spindle cell lesion, possibly neurofibroma and all. In this particular slide, we were aided by the presence of foamy macrophages in the deeper dermis. We have to be aware about the possibility of hystoid leprosy in such a histopathological context. That is the learning point from this slide.
Yes, yes. And also in that case, schwannoma and spindle cell xanthogranuloma, we have to
Yeah.
also,
Yes. Yes.
think about as differentials, which
Yeah.
is fine. But unfortunately, the history also we have given that there is peripheral neuropathy.
No.
Given
In this case, one has to make a diagnosis of hystoid leprosy,
Yeah,
histopathology-wise.
yeah,
No question
yeah.
about it.
yes,
Somebody
yes.
has number 11. Somebody has made a diagnosis of BT, which is absolutely wrong.
Yeah, here we have to give that wrong. Even though they've called it leprosy. I mean, should we give it 0.25 given that we've given lepromatous 0.5?
No. 0.
Okay. 0.
In
Okay.
fact, there are some cases I definitely feel we should start having minus 2.5 also.
That
Somebody
is
has
later. We
taken
want
out.
to encourage people to participate. No, sir. We can't give them minus marks. They stop participating. Okay. Fine. So I'll just close this then. We've got 7, 8, 9, 10, 4 more cases to go and only 30 minutes left. So let us quickly go through the discussion. We'll have to be quick with the remaining ones. So this was an interesting case. I put it because of the histology basically. And maybe once Dr. Lavanya discusses this, we'll see. So this is the dermoscopy showing a nodule with a lot of telangiectasia. And you can see the nice big nodule here on the cheek. Lot of telangiectasia. And this is a 41-year-old female with 1 month history of asymptomatic lesion on the right cheek, sudden onset, increasing size over 4 weeks, no history of trauma, a lot of other non-specific history features, and DD, B cell lymphoma, basal carcinoma, granuloma faciale, and sarcoidosis. So this is the histology I got, and yeah, I put this in because it's a routine sign out. There are some inadequacies, and to highlight it, that's what I put in here. Dr. Lavanya, Dr. Manoj Singh, sir, you may want to take this through.
Yeah.
Okay. So The slide shows a section of skin biopsy where large of the tissue has not seen in the section. And the dermis at this power shows a diffuse infiltrate.
Yeah. Oh, yeah.
So the dermis is composed of
Yes.
varying sized lymphocytes. Some are small, medium, and some large also, I felt. And it is distributed in a diffuse manner. And there is some entrapment of hair follicle in between and collagen bundles. So I just came with the diagnosis of cutaneous B cell lymphoma in this case. Uh, like it because the infiltrate was diffuse. And clinical history also short duration. So I thought of cutaneous B cell lymphoma in this.
Manoj Singh, sir?
You see, the here also the gray zone is distinctly made out. Cells are going into it, but distinctly different from the masses which are happening below. Yeah, I would tend to think along similar lines that if this was, where else do you have this kind of a mixture of cells? The other one condition, of course, well, this is not really, is something like a, benign cutaneous lymphoplasma. But when you have something like that, then you have to have distinct, some follicle formation, nodule formation, some differentiation. This is diffuse. This whole thing is diffuse. So I would definitely go along with her for a lymphomatous process.
BT, would you commit yourself, sir, or are you,
T.
will you? Okay, and for the benefit of people who are not dermatopathologists, why B and not T? And why not pseudo?
But pseudo, as I said, because of the lack of, structures.
What structures are we talking about, sir? I mean,
Lymphoid
I'm not
follicles.
lymphoid follicles. Yes, yes. Okay,
Lymphoid
okay.
follicles. When there is such an extensive inflammation in a benign lesion, then definitely, some kind of follicular differentiation will be there.
Okay. So before we
And
go ahead with the discussion, sir, one thing I want to point out, this case and the previous case were in the same sign out actually. Just go back to this as well. The reason I'm actually going with this is showing this because there is a processing artifact here wherein the tissue was heated up too much during processing.
yeah,
And this is a
yeah,
typical artifact we see. And when you see that, it is the epidermis, the keratinocytes have this, and even the cells have a distinct blue color. It takes up
yeah,
more
yeah,
blue.
yeah.
And this is a distinct artifact when the technician has made a fault and actually heated up the specimen too much. This is a slightly more overheated coagulated specimen. And this makes the morphology very difficult.
Very
And
difficult.
when this happens, I have realized that I should not commit myself on a diagnosis in these particular scenarios. And this is one of the reasons I put up this case because I find when you have such a biopsy, even though you can not see follicular structures or you may see them, it becomes the nature of the tissue makes it very difficult to actually commit oneself. That is my feeling. What do you have you encountered such processing problems?
Yes, yes, yes. This was not clear in my mind that this is a question of overheating. Shashi, I'd like to see a couple more slides like this. Maybe you might like to send them to me. But anyway,
Hmm. And you can
what
see how it's
Lavanya
cut
did,
because of even the cutting, when the technician tries to cut the specimen, it doesn't cut neatly. You often see this
the rats got
artifacts
to
as well.
it. No, what Lavanya did very cleverly was to go down on the medium or the high power,
Hmm.
and there she is distinctly seeing three sizes of cells which are intermixed, intimately intermixed. Now, the question is, you will not have involvement of one type of cell, heat problem in one type of cell and not in the other type of cell. But hold on, just go down on just go a little. Yeah, hold on. I am wondering whether I am now seeing follicular structures or not.
I think some of them are follicular
Yeah,
structures here.
this one.
There are some follicular structures here. In my mind, there are some follicular structures.
You need
But then,
CD3, CD20.
yeah, in my mind, there are follicular structures here. Nandakumar sir, what do you think?
I wouldn't straight away label it as B-cell lymphoma. I would call it as a cutaneous lymphoproliferative disorder, possibly B-cell because of the Grenson and all, the bottom heavy infiltrate, the classical. Possibly B-cell, IHC markers to be done. That is how I would sign this off.
Yeah, absolutely.
Absolutely. And what did you do? You agree? Have you seen this sort of artifact? Do you agree this is?
Oh yes. In fact, that was the first thing that struck me when I looked at the histological picture. Probably due to overheating. Anyway, the severe artifactual change is seen.
Oh yeah.
Yeah.
And sometimes also due to improper formalin fixation, this can happen, I think.
Yes. I in fact, I thought of fixation artifact.
If the
Probably
formalin is not good, also you see this.
Yeah, you are fortunate in the sense that the morphology of cells, at least in this part of the section, is somewhat retained.
Absolutely. In inflammatory pathology, it becomes impossible to report. If this is an inflammatory lesion, I would refuse to report and request the clinician just please send another biopsy because of a technical issue. And that is a good learning point for junior pathologists. If you're reporting, please don't report. Morphia cases are impossible. If it's a morphia case and you're seeing this entire section is blue, impossible to make a diagnosis of morphia. Impossible.
It is a good learning point. Never sign off on a slide which is inadequate. We can give the report as if the sample is inadequate or improperly processed. Ask for a repeat biopsy.
Actually, do you have any other cuts of this, Sasi?
All the cuts are similar, sir. This is the only cut.
All are similar.
All are similar. So deeper cuts.
Because one of the things you can ask your technician to do is to cut 3 or 4 and stain them slightly differently. It at times may make a difference.
Sir, any input on the follicular structure? What should we call it?
It's a follicular structure. This thing you can make out.
Not the lymphoid follicle, sir.
No, this one, this big one.
Yes.
This big one is probably a keratin plug. And you can make out the follicular epithelium around it also. As Dr. Sasi said, between epidermis and dermal lesion. But here you can make out that there is follicular epithelium, which is actually taking off from the epidermis. And this is a huge follicular plug. You may or may not be seeing a hair follicle in the middle of that.
No, clinically they're comedones. That's what the dermoscopy reveals, comedone-like openings. So that's
follicular plug.
Okay, so let's move on to the answers because you've not got much time. Case number 7, we have to decide how to label this. So I think we have to give, because we don't have, this is not a sign out, this is a quiz. Yeah. So they don't have the option to say they can't they have to commit to either one. So pseudolymphoma and cutaneous B-cell lymphoma in my dictionary get equal marks, but up to you.
0.75 for both.
0.75 both. Do you agree, Manoj Singh? So you okay with that?
Yeah, I think it's okay.
Pending IHC, you don't have IHC anyway. Merkel cell carcinoma metastasis, I don't know where that came from. They don't look like Merkel cells. Diffuse large B-cell lymphoma.
Well, as Dr. Lavanya very clearly pointed out, it is not diffuse. It is actually a mixture of cells.
Yes, and not just large B cells. So again, pseudolymphomatous folliculitis, no, this is not the picture of that, though there is follicle that doesn't make it that. And none of the others get any marks.
Number 11.
Lymphomatoid papulosis, single lesions, sir, no chance.
Well, actually, you know something, Nan, to be definite about lymphomatoid papulosis, this was only in retrospect that when we were going high and low, and so maybe there is some follicular thing. But lymphomatoid papulosis, as I started off saying, will have recognizable follicles, lymphoid follicles. You don't have them here. Here, all that one is able to see when Sasi was going high, low, high, low, high, low, and say, oh, maybe there is something there, maybe there is something there. Now, that may be because of the destruction or, the heat degeneration, but not more than
Then
that.
clinical is or not that of lymphomatoid papulosis.
Yeah, it is
Yeah,
not.
absolutely. You're right. You're right.
So, okay. So 8, 9, 10 remaining. Let us go quickly. So case number 8, 60-year-old male with reddish raised lesions on the body for 3 days. Multiple erythematous plaques in the posterior tongue with central vesiculation, necrotic ulceration. Few regions scattered on the chest region, mild itching present, insect bite reaction. Now, this is a classical case, but it's difficult. It's classical but difficult. Who wants to take it? I think Dr. Shishirdas, do you want to take this?
Okay, sir. So we can see a skin biopsy where the epidermis is pale with reticulate degeneration of the upper layers of the keratinocytes, upper layer keratinocytes, and there is a vesicle formation which split at multiple levels, and numerous neutrophils. I cannot see any acantholysis in this, and there is a lot of necrotic keratinocytes in the upper layer.
Yes. Anything else?
In the upper dermis, there is some mixed infiltrate with predominance of polymorphonuclear cells, and there is in some parts there are some leukocytoclastia.
Eosinophils also, I think.
I cannot see here.
Maybe not significant, sir.
No.
No. Maybe that is one, but difficult. Is there vasculitis, Dr. Shishirdas?
So I don't think there is much vasculitis here. I don't think vasculitis here.
Endothelial cells look very swollen, though. Don't you agree?
I think there is. No, but the one you have got, the one next to it, in fact, we are seeing inflammatory cells in the wall also.
There are inflammatory cells within the vessel wall, but that's allowed in a capillary, right? If it's only there in the medium, large
but when
vessel,
you have
that
so
can
There
many,
is no fibrin deposition or any RBC extravasation there. So
no, there isn't.
vascular damage I don't think has happened here.
So you're saying vascular damage has happened or hasn't?
No.
Hasn't happened, I think.
Yeah.
This
Is it called
when
dermal hypersensitivity pattern or something?
So look at the number of amount of leukocytoclasia here.
Yes, there is a leukocytoclasia, but
And what about this vessel here?
there is some thrombosis, I see.
And I think there is fibula. That vessel is completely destroyed, right? I think that was fibula necrosis of the vessel wall.
Okay, this one looks vasculitis. Yes.
So there is definitely some amount of vasculitis is there.
and there again, this what Cecil had mentioned about RBC extravasation, that is a rather fallacious observation, because a vessel wall may leak and close, which means it has leaked 10, 12, 13, at least in one section, 10, 12 RBCs. And because I remember several cases where, we had this in mind way back that, if you don't see RBC extravasation, it is not vasculitis. And, you do 2 or 3 step sections. And in one of the step sections, you will see vasculitis, this extravasation. Then you go back in the other 2, 3, it is not there. It is there only in one place. So that can be, exactly what you said, that, it may be either coming or going, or it has not yet happened, something like that.
Yes.
So what's your diagnosis, Dr. Shishudas? What do you think?
So I actually missed the vasculitis. So I put in, I think, bullous erythema, and
Sorry, your voice broke up. What you put in what? Sorry?
I put in bullous EM,
Bullous
and
EM.
also
Okay.
some kind of viral cytopathic effect could lead to this. So I also put in eczema herpeticum. So
Okay.
this was my thinking.
Okay. Manoj Singh,
Yeah,
sir, any other
focused on
thoughts?
the reticular degeneration mainly.
Because of reticular.
Virus, no. Virus, no. Because, my thing is that, even the epidermis is not really looking like it's looking more like a kind of an artifact, or maybe a reactive this thing, not one of viral processes. And then a virus process or a herpes process, why would it cause so much vasculitis in the dermis? You know, herpetic dermopathy or dermatitis, usually not so, small vessel, medium vessel, fairly large vessel, everything is involved. That usually you don't see in one biopsy of herpes. So I would not think of a viral process. The other ones, yes, perhaps.
Dr. Lavanya, what were your thoughts? Sorry, I forgot to ask you.
Sir, I thought of actually neutrophilic dermatosis. I thought the vasculitis is a secondary phenomenon. Actually, I thought of pyoderma gangrenosum in this. I thought the neutrophils are infiltrating and some amount of necrosis is there. So, and the vasculitis was seen in the adjacent vessels like that, I thought. So my diagnosis was pyoderma gangrenosum and second diagnosis for neutrophilic dermatosis.
Okay. Nandakumar, sir?
Yeah, I was thinking in terms of a rickettsial infection. Why not? With the necrotic keratinocytes, neutrophilic vasculitis, will be rickettsial infection. Can produce both these changes. The
So this was a clinically a classical case of varicella zoster, by the way. Sorry, not
oh,
zoster, varicella virus, varicella infection, not zoster. It's not eczema herpeticum, but basically it's chickenpox that the patient had second time, and yeah, resolved within a week of antiviral therapy afterwards. Um, Actually, Dr. Shishudas point out the reticular degeneration and the vasculitis. These are both classical features described in varicella infections in the textbooks. Vasculopathy, vasculitic changes, and reticular degeneration and intraepidermal neutrophils are
Wow.
all part of varicella infections. You may or may not see viral cytopathic changes, but the reticular degeneration and the keratinocyte necrosis are all quite typical. And also, you're seeing quite large endothelial cells. So these sort of this sort of endothelial cells imply that there is a lot of these are part of high endothelial cells. Large inflamed endothelial cells are also part of viral cytopathic changes generally described in herpes. So this is a case of chickenpox actually in an adult.
Oh, I am educated.
So this was the classical case I put up. I didn't deliberately put the clinical pictures because the clinical pictures were classical actually.
Classical, yes. But yeah, you may like to, in our library, you might like to include them.
Uh, so yeah, so we'll quickly mark this, and yes, we'll take that into consideration that what everybody thought. So we don't need to go with the actual clinical diagnosis. We can basically give marks to whatever everybody else thought. So bullous EM is not unusual because there's quite marked epidermal necrosis, but there's no interface change to call this EM. I mean, the interface change should be prominent, right? What do you think? EM, should we give that an answer? Give that marks?
there is no interface change. I don't think EM is a serious diagnosis in this case.
Mm. Because I
cannot.
didn't think of EM. The epidermal necrosis is there, fair enough, but it's actually reticular degeneration and neutrophils, again, unusual in EM per se. Somebody called it neutrophilic dermatosis because of neutrophils. Again, I wouldn't give that any marks personally, but I'm happy to consider marks if there's nobody has called it. Rickettsial infection, somebody has called it.
Number 8.
Number 8, eczema herpeticum. Yes, eczema herpeticum
See,
certainly.
but again, I was actually, I did, when I was talking, I was thinking of herpes. Herpes is very characteristic epidermal changes. Epidermal. Again, this coexistence of herpes changes or viral changes in the epidermis and such marked dermal vasculopathy is something which is
But
education for
vasculopathy is
me.
typical of herpes, sir. It's been described. Herpes vasculitis is typical. It's a well-known entity.
No, it is. What I am surprised by is the fact that small vessel, medium vessel, large vessel, everything seems to be getting involved. So this is something I've never seen before. So because when whatever biopsies we have of viral this thing, you look at the epidermis. Actually, I don't remember having seen whether it was a superficial biopsy or whatever it was, but you don't really look too deeply at the dermis.
So are we giving any marks because we have to consider that I know this is the final diagnosis is easy once you've seen the clinical, but they've not seen the clinical. So based on that, I'll let.
I think this herpeticum 8 number should get some marks.
Yeah, 0.5 marks. We should be given.
Okay, what about the remaining ones then?
Remaining are the differential of any, this kind of inflammation, vasculitis, that group.
No, except perhaps, we cannot consider eczema multiforme based on histopathology in this slide.
Yeah.
Arthropod also, I think, is very unlikely,
No,
but
not arthropod. No. Not
rickettsial
scabies.
infections, what do you think, sir? You mentioned
No.
rickettsial.
No.
Nandakumar, sir, you mentioned rickettsial.
Seen few cases of rickettsial infections here. The histopathology does fit in a lot of necrotic erythrocytes and touch of leukocytoclastic vasculitis.
Okay.
Perhaps 0.5 marks or 0.25, perhaps.
Does the
0.5.
clinical fit in for rickettsial infection?
No. Clinical doesn't fit in. Clinical doesn't fit.
In that case, then we can't give marks if that.
Yeah, we can't. Okay, fine.
TN again, TN, what do you think? I mean, no vasculitis, vasculopathy is unusual in TN, and also the neutrophils are unusual. Again, no interface change really. I don't know.
Not really.
Yeah. IgA pemphigus, because of
No.
neutrophils, somebody has called
No.
IgA pemphigus.
No.
Arachnid bite, febrile ulcer necrotic Musha Haberman disease. Again, you need to see interface change for that. So we're only giving eczema herpeticum 0.5. Remaining, we're not giving any marks. Perhaps should we make that 1 then, because there's no other better diagnosis?
Yeah, give it 1.
I think one can give. Rickettsial infection 0.25 marks may be given. You
0.25,
discount.
you think?
Yeah.
Okay, fine. Okay, so I'll submit it as it. Then we've got 2 more cases to discuss in 10 minutes. As people will curse us for keeping them long. So cases number 9 and 10. So 49-year-old female presents with 2 lesions, one 5x6 mm nodule on the right shoulder, tender on palpation, slightly erythematous shiny surface, and another 7x7 nodule on the upper back. Dr. Lavanya, this is a classical case. I think for you it will be very easy.
Yes, sir. So the section shows skin biopsy. The epidermis is unremarkable. The dermis shows fairly well circumscribed, defined lesion in the dermis, composed of smooth muscle cells arranged in fascicles. Um, on higher power, the cells are spindle shaped with the blunt ending nucleus. So I thought of cutaneous leiomyoma for this.
Yeah, I guess you can't talk about demarcation because it's only a punch biopsy, but you can see a nice Gren zone here that we've been discussing, if that is relevant or not. But yes, this is a nice leiomyoma. And what type of leiomyoma would you call it in the cutaneous thing? What is the origin?
Pilar
Pilar
leiomyoma.
leiomyoma, yes, yes. And yeah, I don't think there's any differential here. It's a very classical case, eosinophilic cytoplasm. I guess if you're thinking about spindle cell lesions, then you're thinking about neurofibroma and other things of that can be same spindle
No,
cells.
but
You're
this is a
thinking about
live one.
dermatofibroma. But then the classical arrangement in fascicles, and as you said, blunt-ended
Cytomorphology.
cytomorphology. Once you see it, you can't miss it. But if you're a dermpath novice and you're looking at spindle cell lesions, initially all look the same. And I have experienced that as a trainee when I was looking at the spindle cell lesions. But then as you look at these lesions,
No, but
multiple lesions, then there's no other differential. It's actually a
as
spot lesion.
Lavanya and Nand will bear me out, even if you're a dermpath novice, but you have some experience in regular histopath, this looks like a section from a uterus. You know,
Is it? Okay.
quite classically, that appearance of, linear arrangement
Yeah, yeah.
and in between these cells, which is transverse thing, this looks quite like a uterus.
And on transfer section, these the spindle cells in leiomyoma appear like this, right? This clear cell.
Yeah.
They sort of, I don't know what it's called. Is there a particular name for this pattern, sir? When you have this sort of clear cells appearance in transfer section?
No, not that I know of. Not that I know of. No.
Often in muzzle, you see that on transfer
But
section.
I'll just look it up.
Dr. Lavanya very nicely described the morphological aspect of the spindle cells. In fact, for our last CPC, we had a neural tumor where the
Schwannoma we
nucleus.
had, right?
Yeah. So the nucleus had a pointed end. Here it is a blunt-ended one. That is one morphological feature worth looking at.
And one more thing, I mean, here you could argue that they're pointed, so it can be confusing sometimes, but they're not wavy. In the neural tumors, they're all wavy. Here, it's not really wavy. They're pretty straight, like a cigar.
Cytoplasm is also a clue, isn't it?
Eosinophilic.
The cytoplasm has numerous fibrillar patterns going the same.
Yes. And this appearance is classic. I mean, muscle fibers, when you cut in transverse section, they have this appearance as if they're sieve-like appearance. And that's very classical. Once you see that, I think your diagnosis is done and dusted. Okay. We'll just go for the marking and move on to the next case because this is pretty easy. Won't spend too much time on it. Oops, this is case number 9, right? Okay. So pilar leiomyoma is getting 1 dermatofibroma, cellular leiomyoma. Leiomyomatosis. So that's one of the things I left that thing in the thing because when do you call something leiomyomatosis?
When there is more than one lesion.
More than one lesion. So do you call it a leiomyomatosis? When you say leiomyomatosis, are you not implying a systemic entity already?
No.
A systemic association?
Yeah. In the sense that if you have 2 biopsies from 2 lesions, then you can say, or if you have a description, that there are multiple lesions and biopsies from
So
one.
there are 2 lesions in this patient. Would you call it leiomyomatosis? Would you give that? Is that a good?
We need not use that term here.
I would tend to avoid that altogether.
Because that implies there are internal other organ involvement and everything else, right? I mean, you're implying when you're saying leiomyomatosis, you're saying that there's something else going on.
No, as far as I am concerned, I like to say that, okay, this biopsy which I am seeing is showing this.
Yes.
And leave it for the clinician to do the summing up.
Absolutely. But then they've called it a leiomyoma, so again, we have to give the marks.
Yeah, okay, I think so.
How many? 0.75 or 0.5?
I think 0.75.
0.75.
0.75. You see, the point is that here we are also kind of, even though the imperfection is from our side, that, our drop-down menu is not as comprehensive as it could be. It never will be. So, but, you know, if you call it just leiomyoma, that is one issue. If you are going ahead to classify it further, pilar, what does pilar mean, by the way?
Arising from the pilar muscle, arteritis pilarum.
Or as opposed to arising from a blood vessel?
Yeah, it is called angioleiomyomata, so it's not angio, so it has to be, any cutaneous is either angio or pilar. There are only two options.
Okay.
So cellular leiomyoma, I'm not sure I would go to that extent classified as a cellular leiomyoma. I'm not sure if there's any implication to it anyway, but
I mean, there is no reason why to call it cellular, yeah. It is cellular.
yes.
If it was not cellular, then it would be a fibro something or the other.
Yes. I don't know. To call it cellular, I don't know. Why do we call it cellular? I don't think we need to call it cellular.
It's an
we
unnecessarily used term,
correct.
Point-
Pathologists need not
0.75?
unnecessarily
Yeah.
commit on hair splitting
Yes.
terminologies.
It is there in the book, fair enough. But 0.75, I think, will be, if you're giving leiomyoma, cellular
Oh,
leiomyoma
sure.
also 0.75. One
I
for
think
the remaining.
None of the other ones.
None of the other ones. Okay, so last case, and then we can wind up.
this is submit. Yeah.
Okay, so last case is okay. This is actually very interesting case. Dr. Shishir, I'll give you this case because it's interesting. 38-year-old male, itchy raised regions of buttocks for 2 months, well-defined plaques with central atrophy, scaling, pigmented margins, intense pruritus, ill-defined pigmentation present over the natal cleft. Lesions did not respond to antifungus and partial response to steroids. And the clinician thought this might be lichen sclerosis. What did you think?
So this is a punch biopsy of skin. This is what I would like to call it is invisible pattern. There is nothing going on, and there is some parakeratosis I can see.
There is what? Sorry.
There is some parakeratosis.
Okay.
So let's go into the parakeratosis. You can see. I looked at it in higher power and I found some hyphae.
Absolutely. I think that was the point I was trying to make, and well done. I think you see beautiful hyphae. This is a H&E stain.
Yes.
And the number of hyphae you can see here is phenomenal. Can you see that? You can make out the hyphae, not some hyphae. It's just teeming with hyphae. You don't even need a PS, and that's why I put this here. This is a H&E stain, and you're seeing beautiful hyphae.
Yeah.
And this is not invisible. This is very much visible dermatosis.
As for patterns go, we call this. I was taught to call this invisible pattern.
Shashi, your case?
Yes, sir. Yes.
Can you please ask your technician to cut 3 or 4 thin sections of this?
Okay.
And then look at them and see whether you can make out the, because what you are seeing here, usually you don't see these, right? Even when there's dense involvement, you don't see.
They are teeming, sir. Normally we see 1 or 2 hyphae, even PAs. This is
what I am saying is you just get 2 or 3 thin sections.
Okay.
And obviously the staining will be different from this. And then look at those.
Okay. So yes, this is a classical case of tinea.
Yeah.
Let us see how many have got it right.
Yes, let's see. Case number 10. So 11 have gone for lichen sclerosis for some reason. So only 5 have got it right. Out of 20, the rest have got it wrong. Okay. So 5 out of 20. But well spotted, Dr. Shishidas. I mean, that is a well spotted.
Yeah, I'm really impressed. Very well done.
Excellent.
Yes, I think both of you have done very well. We missed the other 3 participants who were supposed to be here. So unless there are any other closing comments from anybody in the panel. Dr. Nandakumar, sir?
No, I think we discussed the slides very well, and Professor Sirdas and Dr. Lavanya, you're doing an excellent job. Observation-wise, you are top class.
Yes, I
Thank you,
think
sir.
exceptionally well, both of them. Dr.
Thank you,
Sishudas, you're not
everybody.
doing any signing out, right? You're just interested in Dermpath.
Yes, I'm just interested.
Well, you're doing very well, actually. Yes, it's a pleasure to have him as one of the co-editors of the Indian Journal of Dermatopathology. So he's doing excellent work there as well. Dr. Manoj Singh, sir, any closing comments?
No, thanks.
Excellent.
Good night.
Dr. Sishudas, do you have anything to say?
No, sir, I learned a lot, especially on the varicella case. And these are very nice.
Dr. Lavanya, do you have anything to say?
Very nice cases, and discussion part was very good, sir. We learned a lot.
Excellent. So now I can also announce the result. Dr. Lavanya, you scored the top this time with
Okay.
695 out of 1,000 points, potential points at 97.5 percentile. Dr. Shishudas, you're second at 92.5 percentile. Well done.
Thank you, sir.
Okay. Thank you all. Thank you very much. Until next time.
Night, everybody.
Good night. Good night.
Good
Good
night.
night.
Good night.
Good night.
Thank you, sir. Bye bye.